let's move on to our guest speaker, Dr. Sree Koka, who is the Dean of the University of Mississippi School of Dentistry. He's a native of the United Kingdom, and he received his dental degree and specialty training in prosthodontics from the University of Michigan. He also holds a Ph.D. from the University of Nebraska and an MBA from MIT. And his topic today, complete dentures, it seems to be receiving less emphasis and time in today's dental school curriculum. And as the dean, you can certainly comment on whether I'm accurate in that remark. But based on cases coming to the lab, that's my that's my conclusion. But it's such an important procedure. It's so basic to our overall understanding of dentistry, aesthetic dentistry, occlusion. So I'm really excited to bring Dr. Sree Koka with his lecture, Complete Dentures, the easiest and the hardest procedure. Sree, it's all yours.
Thank you very much, Neil, and to Glidewell for having me here to do this. I love teaching complete dentures. My practice before academics was a practice that was actually focused on removable prosthodontics. So 80% of my patients were either complete denture or RPD patients. So I really do love this topic, and I'm excited to share it. I'm going to start out this presentation with a philosophical overview, and I'm going to ask you this question right up front, which is, do you believe in evidence-based dentistry? Yes or no? Now, if I was in front of you in a lecture room, I would have you raise your hands and I would see how this goes. And I'm going to try and convince you today that evidence-based dentistry is a flawed approach to practicing dentistry. And we're going to use complete dentures as a way of talking about that, okay? What I don't like about evidence-based practice is that it subsumes patient values to being only a third as important in the whole process as the evidence itself and clinical expertise. And I would argue that we really need to focus on what patients value. And my goal today is to get you to think about some of the things that we've all been taught as being critical to making great dentures, maybe are really not that valid anymore. And what should we be doing instead that would actually make our lives easier, but also make the product that we give to a patient, the service that we provide to a patient, maybe even better. So, simple question for you. Do people need teeth? Think about that for a couple of seconds. And then think about, do people want teeth? And think about that for a couple of seconds. And, years ago, I Googled the best smile in the world, and a picture of George Clooney came up. And if you look at this face, it's George Clooney. Who doesn't want to look like George Clooney? Now, if we just cut out the bit that was his smile and stuck it up there as us dentists, we'd be picking this smile apart and coming up with all these reasons why it's not perfect and maybe he needs to go visit one of us. It doesn't seem to have affected his career progression very much, though, does it? And then if you look at this person, selling a T-Mobile phone, a lovely, perfect smile, right? Something that, again, we would all aspire to creating for our patients. But if I ask you, who is this? You might come up with some names of models, but off a tennis court, you may not realize that this is Maria Sharapova. On the other hand, who needs a smile to be famous? Here's Darth Vader, one lightsaber swipe away from controlling the whole universe. And again, not having a smile didn't hold him back. And yet, another person without the best looking smile actually vanquished him and even had a postage stamp named after them. So just to be a little bit funny with you still, which of these 5 people did not receive the Nobel Peace Prize? Think about it again for a minute, and hopefully you figured out my sense of humor and you realize it's the person without teeth. Back in the 40s, in the mid-40s, the Brits worked behind the scenes to make sure Gandhi did not get the Nobel Peace Prize, even during war times when the prize was not even awarded, but yeah, probably deserved it. So back to being serious. Here's evidence-based dentistry. It's the standard definition, right? It's conscientious, it's explicit, it's judicious. It's about using evidence. And Victor Montori, a good friend of mine, who is one of the world's leaders in patient-centered care, he runs the Knowledge and Encounter Research Unit at Mayo Clinic. He said, Sree, there's only 2 rules when it comes to evidence-based dentistry. The stronger the evidence, the more confident we can be in the results. And number 2, the evidence alone never makes the decision. And that's the really important role here, right? So we are making decisions about dentistry based on evidence, but the evidence should never make the decision, even though we're saying that it does. So here's an example of a patient. This patient, if we saw them today, if they walked into our office, the odds are really good that we'd be talking to them about edentulation and thinking about some options to replace all their missing teeth, including complete dentures that we'll come to in a bit. We've got political, cultural, legal challenges. We've got common sense. What should we do for this patient? And we've got that major issue of what the patient compliance might be that should impact a lot of our treatment planning discussions anyway. Now, this person was not seen in the US. This person was seen in Switzerland, and you know, that Scandinavian Swiss way of looking at periodontally involved teeth. Well, this person really wanted to keep their teeth. And you could argue that, yeah, they have a condition of partial dentalism. They have a history of periodontitis, yes, but actually their mouth is healthy now, and it wasn't before. One of the things that we struggle with in all forms of dentistry is the mindset of our patients. So this is actually data taken from a study in endocrinology, and it asks the question, for diabetics, how often do diabetics take their metformin? How often do they not? And if you look at it by patient personality, it turns out that the accepting patient, the one who believes they have a problem and they believe that the medicine helps them, still forget to take their metformin 17% of the time. The ambivalent, indifferent person, the whatever person, somewhere between 25 and 36. The skeptic is our number one problem. And I find that in complete denture therapy, this becomes a really important part of the process, which is figuring out what are my patients' expectations. Do they believe they have a problem, but do they actually believe that the therapy I'm going to provide is going to help them? Because skeptics are spending energy to not believe you, actively not believe you. And I would say the best treatment planning decisions I've ever made have been the ones where I've opted not to take care of a skeptic because I couldn't make them happy. So the easiest and hardest part about complete denture therapy actually starts right here with, should I even be treating this patient? Because, yeah, making complete dentures is not easy. It has lots of challenges, but you're really treating the mind as much as you're treating the mouth. And again, these are our patients, right? Yes, we want them to be engaged in what we're doing every day and believe that that what we're doing really will make a difference in their lives. But most of our patients are struggling with being overweight or having diabetes or worried about their job or having to take 1 million pills, right? So that's an important factor to consider. I would ask this question of you: who defines the needs and wants of the patient? And we struggle sometimes with the fact that we have lots of external stakeholders that impact how we provide care and how our patients choose care, right? Or if they choose care at all, you know, insurers, government, and then societal aspirations. But I'm going to argue again that it's always the patient. And we as dentists tend to be the kinds of people sometimes who assign self-worth to ourselves and feel good about ourselves by all the stuff that we know and that we can help patients make decisions. And sometimes we get a little too heavy-handed, I think, in making decisions for patients. So I don't like evidence-based dentistry. I much prefer the phrase value-based dentistry, and I like it because it has a double entendre. And the first one is that it relates to the beliefs of a person where they are emotional. And Steve Eckert from Mayo Clinic years ago said to me once, he goes, Sree, our patients come and see us for one of three reasons, typically, sometimes a combination. They either want to look better, they want to feel better, to get out of pain, or they want to function better. And if you can figure out what those three are and which is the most important, we've got a shot. And I think this is actually quite true. So we spend a lot of our time just worrying about these three things, because then we can make somebody happy or see the person that we can't make happy. But the other part I like about value, the second entendre, is that it's about, well, I'm giving up something to get something. And typically you think of it as value for money, right? But it is important to our patients. They will make decisions based upon their checkbook, but not entirely, but it is a major consideration. So a few years ago, I was asked to be on the American College of Prosthodontists Specialty Recognition Task Force, which every X years, the ACP has to submit a document to justify why the specialty exists to the ADA. And I was on that task force, and we looked back through the literature, and we could actually find almost no evidence that people need teeth for physical health. Today, you can actually probably drink the nutrition you need, right? And so do people really need teeth? Well, from a physical point of view, I would argue no, but from a psychological point of view, I would argue absolutely. The Mayo Clinic, we run off this equation a lot, value equals quality over cost, and we're trying to run this through the patient's eyes. Is what they're getting going to be worth the money that they spend? What is the value that they're getting? A lot of places in healthcare will focus on quality, and I think that's important. But if there's no conscientious decision making around cost, then I think that's a big mistake. And people will say, yeah, but these are really nebulous terms. And at Mayo, we said, no, they're not nebulous terms. We can measure quality by looking at the outcomes, the service, and the safety. And we can measure cost. It's not just financial. There's biological cost, time, effort, opportunity, psychological. Getting your teeth out is a big deal. It's a big psychological line in the sand to cross. Have to get a babysitter, take time off work, get a ride. You know, all these things impact whether or not a patient will go through with therapy. I think we overemphasize how much the money is important. And I'll use this study, which was fantastic, as an example. So Joanne Walton and Mike McEntee published this paper. It's 10 years old, but they conducted a study in Vancouver. They looked for people who were struggling with complete dentures. And if they passed a bunch of inclusion criteria tests, they enrolled them in a study where they were randomized to either getting new complete dentures or getting implant overdentures in the mandible absolutely for free. After being randomized to the group that was going to get free dental implant therapy, a third of the patients pulled out of the study immediately. So it became a second study, like, why would you do that when this care is free? And it turned out by far the number one reason why people pulled out is that they didn't want surgery. They were just hoping to get free dentures. So again, the biological/psychological cost was too high. And it's important not to discount that. It's also important to understand that every patient has different expectations and aspirations for quality and cost. And that's why I don't like evidence-based dentistry. It takes these studies that sort of say, well, in 1,000 patients, this is what we found on average, but none of our patients are on average. And I think evidence is useful. It can be a guidepost, but it cannot make the decision. One of the places where we struggle a lot as dentists, and I see it with my colleagues, and I even see it with our students here in Mississippi, is that we have grown up in a system where we have been told that if you do X, Y, and Z for your patient, it means you are a better dentist. It means you are providing better care. But I don't think that's true. I think there's a lot of things that we do for our patients because that's how we were taught, and we just assumed that it was a good thing. So if you look at the y-axis patient value and clinician, and the x-axis is for clinician value, it's really not a problem when you and the patient both think that something has low value, or we both think that a treatment has high value. Where we get into trouble is where we think something has high value and the patient doesn't seem to care, or the patient thinks something has high value and we don't care. And this creates a real bit of tension between us and the patient. We might think that they should choose option X, but they don't see the value in it, okay? So with all that as a background philosophically, let's come back to complete dentures. And I've got another question for you. When making dentures, do you routinely use balanced occlusion, a face bow, centric relation, and elastomeric impressions, some kind of polyvinyl siloxane or polyether material? Hopefully, there's probably not too many of you still using polysulfide, but you might be. Is it yes or no? And it might be yes to some of these and no to some others, but just now I want you to think about, why do I use all these things? And I've been around the block a few times. I've made a ton of mistakes, and I really like this quote by Miguel de Cervantes, who says, "Time ripens all things. No man is born wise." I mean, I've made a ton of mistakes, but making mistakes is not enough because it means you've had the experience of making mistakes. But if you don't actually learn anything from the experience, you're not going to get any wiser. And that's the key. It's getting wiser, right? And I love this quote by Leonardo da Vinci: "Wisdom is the daughter of experience," meaning you have to have experience, both good and bad. And from that, then can grow wisdom. And what I'm going to try and convince you of in the rest of the presentation is, yes, you've learned a lot of things. You're very knowledgeable. We're all very knowledgeable. We've been rewarded for having a high IQ and being able to learn a lot of stuff and information and being able to spit it out on an exam or a board exam or whatever it is, right? We're really good at that. And knowledge is when you learn something new every day. But I'm going to try and get you to let go of a whole bunch of stuff that you have been told that if you didn't do it, you were a bad dentist and your patient was not going to get good care. So let's start out with something simple. Let's start out with elastomeric impressions, okay? Now, I'm going to mix and match in this presentation with some science taken from the literature that looks at these questions of elastomeric impressions, of balanced occlusion, of centric relation, and face-bow transfer, to try and get you to think differently again about how you're going to take care of your next patient. And I'm going to ask you to let go of some tenets that you might have held for a long time. So Gunnar Carlson published this paper again 10 years ago, but it's a great paper. And it says, when you're doing complete denture impressions, what should you worry about? And it turns out that if we want evidence to justify one or the other, there actually isn't any. There's no good studies supporting the use of using elastomeric impressions or border molding or post-dam, okay? And in fact, there's studies that show that if you just use a simple alginate impression in an edentulous stock tray, you're going to get exactly the same quality of results as you would if you went through all the expensive stuff. The added appointment, the added cost of an alginate impression that's a primary, of making a custom tray, of using extra elastomeric impression material, using a border molding material. This is all money. This is all time. And you don't need it. This is another great review paper out of Japan and says, well, you know, although that classic primary impression, secondary impression, you know, final impression concept is still taught in textbooks and universities, there is no literature to support that that is a better way consistently to take care of patients. So in our practice, what do we do? In our school, what are we changing to do? We are moving to using alginate impressions as our final impression material. Now, you have to use it in a smart way. So look at this little picture on the left. We have an alginator, which gives us a much more consistent mix of alginate every time. We have to get the best out of the material. You have to pour these impressions up within 10, 12 minutes of taking them. No excuses, no exceptions. We use a kind of alginate that allows us to have enough time to do some of that border molding with our patient once we've got the tray in. We always use edentulous stock trays. We use the one that fits the best. Occasionally, there isn't one. You do have an aberrant jaw shape that in that instance, then we do make a custom tray. But we're using alginates 95% of the time as our final impressions. And we use an alginate syringe, which you can see there on the left. We customize the edges of the tray with rope wax or utility wax. What I'm showing you on the right-hand side there is I always extend the borders of the tray using rope wax vertically, except for the posterior extension where the rope wax goes inside the tray, because I do not want to have any of that alginate slump away from the palate while it is setting up. A lot of times, based upon the palate configuration, I might be adding wax to the palatal area. So again, I don't have so much unsupported alginate. Just little things that we've learned along the way. But using this material and using the alginate syringe can work pretty well. So we're going to move on now and show you a little quick video so you can see this. So there's the alginator. Make sure that if you ever see my wife, you tell her she's a great dental assistant, because this is her working on the alginate. And she will get this mixed up really nicely, get as many voids out as you can. We've figured out over the years how to get the right consistency, because you have to have enough consistency here that it's thick enough for you it holds its shape, but not so thick that you can't get it out of the syringe. Always use a mirror. Pull that out and start injecting way back. And now you can see that with the syringe coming anteriorly, you're not going to trap any air up there. You come to the midline, you flip around, you come to the other side, start weighing the posterior, and again, come around to the front. In the meantime, your assistant is loading up your tray. And here comes the tray. We'll pop that in. This is when you find out if the patient's a gagger or not, but we never talk about the word, we never say it. And so you switched hands, you do some border molding. That helps you with the distobuccal border there of the denture. Do a little more border molding.
You're free little massage here today. You didn't get too much on your face. Now we just got a couple of minutes to wait, and then we'll done.
Yeah, so much like a cooking show where they then bring the cake out of the oven. Here is what happened a couple of minutes later.
All right, time to get this thing out of your mouth. Okay, so good. Feel better?
They're going out, they're going in.
There are a couple of little voids there that we can manage easily enough, but we picked up the vestibule. There's no real worries about where the vestibule is. You can tell the difference in thickness here on mandible. I mean, side to side, shape this side more than this side. And we've got more thickness over here, which means in the final prosthesis, we can trim this back now before we pull it up, or we know we're going to have to adjust the elbow. This is probably a pretty good area right there, a good sign of how we might want the thickness to be. I would probably spring this in alginate now before I pull it up to try and match the thickness there from the outside. So we have a little bit. So we look on a little tiny bubble there that again we can put in the glass. When you bring that closer to the scale, I don't put nothing thickness from this. Good, lovely lady, lovely patient, and you'll work in.
Yeah, so you look at this impression and that's one of the weaknesses of alginate is that it does distend tissue. So you will get overextended impressions, and that's something that you have to factor in. So it's not a perfect material. It gets us a lot of what we want, but there are little things that we will have to adjust and accommodate as we go forward. You can see some burn through there in the tray as well. That's something that I don't worry about quite so much. I do often record where it is, so I have a sense of, well, when I'm delivering the final prosthesis, is that an area that I have to focus on a bit more that might be a pressure area? But this gets us through what we need. And over time and experience and the research that we talked about will show you that you can make a very functional, successful denture for a patient using alginates. You save time, you save money, and everybody wins. You don't have to think that you're being a bad dentist if you just use alginate, okay? So yeah, if you do the same thing, you can use different kinds of rope wax. You can do this different ways, but I really have found this very difficult to do if I don't use a syringe. So the syringe is important. It's about a 60 cc, 60 ml syringe. They come in different kinds. Don't get the kind with the needle on the end. And I always show that syringe to the patient before I approach them with it, because it could freak somebody out if you came at them with a big syringe. So yeah, those are just little ways of doing it. The mandible is a little trickier. You need more alginate in your syringe because you've got 2 vestibules to fill. I will typically do the buckles first, and then come back and do one lingual and then the other, and then insert the tray and go through border molding movements. But you can get a really nice end result. But again, occasionally, because it's not perfect, you do still have to go back and use a custom tray. So when you think of it this way, there's a cost to the patient and there's a benefit to the patient. And I would say with elastomeric impressions, the cost to the patient and to you, which you then pass on to the patient, is higher financially and time-wise. But the benefit, actually, it's questionable. And I would say it's questionable in the past. And I'm going to come back to one thing about our future that might actually make me contemplate doing elastomeric more frequently than I have. So I'm sort of teasing you with that. Having told you that I love alginates, there's a reason why I might come back and start using elastomeric more as we go forward. And I'll come to that at the end. Now let's turn to another bane of all dental students and dentists, which is good old centric relation. So here's the classic definition out of most textbooks. It's a relationship of the maxilla to the mandible. Condyles articulate in this position where it's up against the thinnest avascular portion of the disc, up against the articular eminence, typically with the condyle being positioned more forward. I say to my students all the time, well, this is an anatomic definition. There is no window over here. So if you pick centric relation and your faculty member comes along and they pick a different one, don't stress over it. No one really knows who was right. Just tell them how great they are and move on. And so there's that position, right, of that condyle that's against the disc. But the bigger question is, like, why do I even do this? Like, why do we care about centric relation? And if you think about the definition, it's an anatomical definition. It doesn't help you in any way answer the question of why. And the most common reason that makes the most sense about why you would use centric relation is because in theory, you've got a condyle against something that doesn't compress much, like a disc, against something that doesn't compress at all, which is bone of the articular eminence. And the argument would be that this is a repeatable position. Well, I will tell you that a lot of people do not bite the same way every time. And there's certain denture patients where when they do that, you really have to think about using different kinds of denture teeth to accommodate that variable occlusal position. I really don't care whether somebody's in centric relation per se. I really do love it when their bite is repeatable. Okay, that gives me a certain amount of confidence then that whatever position I'm using, if I use that position, they're going to go back to it again and again. It doesn't have to be that anatomical definition. It just has to be repeatable. Again, people argue that CR is more repeatable than other positions, and I would say it might or might not be. Classic study by Frank Salenza out of New York in the 70s. He restored 32 people into the textbook definition of centric relation and came back and looked at those people over the next few years And out of the 32, anywhere from a year to 5 years later, only 2 of them were still functioning in centric relation, which tells you that it's not necessarily a position that people have to be in or need to be in to be very comfortable and have a good occlusion. And Salenza ended up using this classic line in Pross, where he concluded, the precision of the position is more important than the position itself. So my advice to you when you're thinking about denture occlusion is pick a position that is repeatable and comfortable for the patient. Don't stress about whether that's centric relation or not. But once you pick the position, be incredibly precise about the type of occlusion that you create. That makes sense to me, not the other way around, okay? You set up a sloppy occlusion, centric relation doesn't help you. Okay, let's come to another one of my pet peeves, which is the Facebook transfer. So here's this poor guy with this good old-fashioned Facebook, strapped to his face. And the question again is, do you need this? And we also come back to the question of even why do we do this? And a lot of people think it's to relate the maxilla to the articulator. And I will tell you that's really not the why. That's what happens, but it's not why you do it. You really do it to figure out what is the arc of closure of the mandible. So you're trying to figure out on what arc does this mandible open and close. And for certain types of occlusion, that may be important, but in reality, in removable prosthodontics, it's really not important. And here's some evidence to look at this. Here's another review paper that's focused specifically on the Facebook, and again concludes that using a Facebook is not important to get better clinical results, folks. And you can get great complete dentures, great occlusal sprints without ever doing a Facebook transfer. And so here's another one that looked at actually pretty, if you think about classic research study design, this was a good one from Brazil. And the bottom line is the important one here, that they looked at different kinds of patients with different kinds of occlusion, but really the patients that didn't have the Facebook did better than the patients that did have the Facebook used. So again, we have a lot of history, we have a lot of tradition, but it doesn't seem to matter to our patients. And again, here's another one that looked at complete dentures, again, using a simpler technique versus the more traditional complex technique. And for whether it was somebody's ability to speak, to be comfortable, to chew, none of these things required a Facebook transfer. So, I'm a board certified prosthodontist. I realize that I'm committing heresy, maybe blasphemy, by saying that we don't need to do some of these things, but we don't. And our lives get a lot easier. And to be honest, the patients' lives get a lot easier. I don't know how many of you have had a Facebook done recently, but this is no fun. Poke somebody in the eye, hurt their ears. Again, takes time, and time is money. Why do things that you don't need to do? You may not know this, but Henry Ford used to go back and look at all the pieces of his cars that he outsourced, and he looked at which ones didn't fail. And the ones he didn't fail, he would go back to the manufacturers and say, your piece is actually better than I need it to be. I'm not going to pay you as much. Because he didn't want to pay for something he didn't need. So again, why do this? So again, even with Facebook, there's a financial cost, there's a time cost, there's a comfort cost, and the benefit to the patient is zip. Okay. Another bane, good old balanced occlusion, balanced articulation. So, here's another definition I'm giving you. Basically, in excursive movements away from centric, we are maintaining contact of our posterior and anterior teeth based upon the movement as we move away from centric. And understand that this is a mechanically created phenomenon. It is typically talked about in complete dentures. We wouldn't think about this as being a good thing with natural teeth, although some people over the years have ground their teeth into a form of balanced articulation. And again, taking you back to dental school, these are some of the pictures that you remember seeing about how, in centric, there's that interlocking of cusps. And as you go into working, as you go into balanced occlusion or non-working side, you're trying to maintain contact, whether on either side, which we would just consider cross arch, or if you're using anatomic teeth in both arches, times you're trying to maintain two contacts on one side on the same tooth. So we'd call that cross arch, cross tooth, right? Again, the most important question though is, why do you do this? Another statistic for you to think about. Understand that balanced articulation or occlusion can only be relevant when the mouth is empty. Classic Pross phrase, enter bolus, exit balance, right? So you're not going to get balance when the patient is eating. So then the next question comes from that, when there's no food in the mouth, how much time during the day are our teeth in contact? And, normally I'll ask my dental students, during the day, how many minutes or hours are our teeth touching? Most people don't realize that our teeth really don't touch when we speak. They actually touch pretty little, even when we chew. And so the main time that our teeth touch during the day is actually when we swallow, because we put our mandible against our maxilla for bracing so that the tongue can then push food down the throat, right? And somebody's just studied this, and the number of minutes that our teeth are in contact during a day, the average number is 17 minutes, okay? So basically, you're setting up an occlusal scheme. You're going to all sorts of trouble to create this perfect balanced occlusion for something that happens 17 minutes in a 24-hour period. Is that important? Well, another thing to realize is, even if you go through all the trouble of setting up this perfectly balanced occlusion, the research has shown that within a few days, the patient doesn't have balance anymore. And if you think about it, you're trying to create something that relates to a hard surface of a tooth touching the hard surface in the opposing arch. But yeah, our dentures are sitting on mucosa that is compressible and resilient and viscoelastic. It's also being driven by muscle action and our joint action, right? And there's lots of things that influence how all that works, whether it's stress or hydration level, or whether you take your dentures out at night or not. And all these things basically change the foundation on which the dentures are sitting. So it doesn't actually surprise us that even if we had balance on the day we inserted the prosthesis and the patient's left, that we don't keep it. And again, the patient doesn't seem to notice the difference. Here's another study that looked at different occlusal schemes, and they found that complete dentures that had bilateral balance, patients were not able to eat better with those dentures. So if we go back to the why, so then why do we do this? It's typically done because we think there's going to be some localized dislodging force on the dentures when the mouth is empty. And the most common reason why you might get a localized dislodging force is if you have to set an anterior and vertical overlap of your anterior teeth, so that when the teeth hit each other in protrusive, it might knock the upper denture down or the lower denture up. That's the most common reason. And the most common reason to set the vertical overlap is then for aesthetic or phonetic reasons. Occasionally, you might do balance for somebody who comes in with anatomic teeth and you feel like you need to. But I will tell you that a lot of people don't know if they have balance or not. And even if you do set it up, the research says it doesn't make a difference. Another paper suggests that balanced occlusion is not needed for successful treatment with complete denture patients. So again, what I'm getting you to try and think about is, we've had all these rules, and now I want you to make those things like FaceBow, like balanced articulation, like custom tray and elastomeric compression material, like worrying about centric relation. I want you to make those the rules no longer. I want you to make those the exceptions, and understand there might be times when you come back and do this as an exception, but you don't need to worry about all this stuff as the rule. It's a waste of time, and it's a waste of money, and it's inconvenient for the patient, okay? So the conventional prosthodontic wisdom, again, I'm saying this as a heretic, is that you don't need balanced occlusion. It's not going to help you. Now, the problem is that sometimes we think it's a good thing. So again, think of the cost. It's going to take you time. You have to spend more time clinically adjusting for a balanced articulation than you would if you didn't have it. It's going to take you probably more, it's going to cost you more to have your lab do all this extra work. There's certainly extra time involved in doing the extra adjustments for you, and then there's the lab time. And the research says that for most people, the benefit, again, is zip. So why does this challenge us? Why might you feel a little bit uncomfortable about, oh, can I really not do this next time? Well, it's because of that value equation and how we perceive it and how the patient perceives it. So when it comes to balanced articulation, if you look at this patient column of quality and cost, there's no difference to the quality, folks, but you're increasing the cost. The same with the FaceBow. There is no benefit to doing this, but you're increasing the cost. And here's elastomeric compressions. I told you I'd come back to that one and say, well, maybe there's a maybe there, despite how much I love alginate, but there's also a cost there. We tend to think that if we do a balanced occlusion, and if we do a FaceBow transfer, and if we use a custom tray all the time, we think that the quality of the dentures is better. And we tend to think, therefore, that the value equation works because there's 4 pluses for quality. And yes, it has the cost, but we think it's more net positive, right? Whereas from the patient's point of view, obviously, we've increased the cost without any benefit in quality. So we have to dissociate our stuff, our biases, our history, our dogma, really, from what actually matters to the patient. Patient-centered care does not require balanced occlusion, and it does not require a face bone. It does not require centric relation. So why am I saying that elastomeric impressions might be different now than maybe they were a few years ago? And it's because of this. It's because digital dentures are coming. And remember how I said that if you make an alginate impression, you have to pour it up super quickly? Well, that's going to be, it's unless you scan that alginate impression immediately within 12 minutes, which is going to be hard to do, it's not going to be time stable enough. That's one of the weaknesses of the material, right? So there, with what's coming in the future, the ability to scan an impression might require a material that is more time stable. So now I'm going to suggest that there will be times where we need to go back and think about elastomeric materials because it gives us that flexibility. The material gives us that advantage to be a material that can be scanned. I will tell you, though, that although scanning works really well for attached tissues and hard tissues, basically tissues that don't move, we're still not there yet on being able to scan impressions that require us to record the functional movement of tissues. Now, we're going to get there, but I haven't seen a system yet where I'm comfortable with that. So I would say if somebody wanted to do digital dentures, when we do them, we still make an elastomeric impression and we will scan the impression. The other way we can do it is make the alginate impression, pour it up, and then scan the model. And you can do that. At our school, we like to teach border molding. We think that's important. So we like to make an alginate impression so that we can teach all that. You could do that with a custom tray as well. But we also want to teach maxillomandibular relations and all the things that go into it, whether it's vertical dimension and lip support and all that stuff that you can teach with occlusal rims. So we're not embracing all the elements of digital dentures, but we are, from an educational point of view, taking our students through the impression making part, through the maxillomandibular relations part, and then when we get to the case being mounted, that's when we then have the case scanned and digitally involved from that point forwards in some of our cases. Okay, so just sometimes people ask if we're doing digital and we say yes, but not for every step that we could. And we're still waiting to see what we can do, what others can do and teach us about making digital impressions of movable tissue. So I rattled you through all that stuff to leave a bit of time for questions. So my point here is to hit home that you can make great dentures in a very simple way, in a more time-effective way, a more cost-effective way, without compromising the quality of the care for your patients. And if you think about time and effort and visits and all that stuff, it's actually better for the patient for you to use the simplified technique and then learn when you need to go back to the traditional for those exceptions. So you make the simplified technique the rule, and you make going back to something else the exception. And you got to let go of this. You got to let go of this. Well, I'm a bad dentist if I don't do all that stuff. Actually, you're a bad dentist if you do that stuff because you're doing stuff that isn't needed, and that's not actually helpful to anybody. So I'm going to ask you this question: if you keep doing it the old-fashioned way, are you actually just practicing history-based dentistry? Which we probably are. So, Neil, there you go.
Sree, that was great. That was great. I'll tell you, you're just blowing up all this dogma that's out there. And, as a board certified prosthodontist, you have the ability to blow that stuff up where a lot of us have had that experience that some of these procedures are not helping our patients, but yet that's what we were taught. So our audience was all over this. I've got a lot of great questions for you. So let's charge into it. First of all, I love your comment about wisdom is letting go, because there's a lot of stuff that we need to let go of. So a lot of questions about the alginate impression. Is this a special type of alginate? What kind of alginate are you using?
No, it doesn't have to be a special type of alginate. The only thing you have to be careful of when you use it is that you get the right consistency. So you've got to have an alginate that doesn't set up so quickly that you don't have time to inject it. and that you don't have enough time to do a little bit of border molding. But as long as you meet that criteria, and if you have an alginate that sets up quickly, use colder water, put a little more water in it, you'll play with that a little bit to get the right amount of consistency to get it into the syringe and out of the syringe. But it's not.
I noticed you're using Dot was using a power mixer to make sure she got a nice mix there. And yeah, can we talk a little bit about the trays? So these are stock trays. Then you're using rope wax. Are you actually border molding the rope wax, or that comes later when you put the alginate in?
No, it's a great question. So what I do is I put the tray in, and I have a quick look around to see where is the tray a long way from the depth of the vestibule, and that's typically where I'm adding the rope wax. So I put one layer on, but sometimes it's short enough that I have to put a second layer of rope wax on. Okay, so you're building it up to kind of give you what you think is the support you need for the alginate, but still leave a bit of room above that rope wax for you to be able to border mold it. But there are times I don't border mold it before I put the alginate in. I do my border molding one time only, and that's when the tray is in the mouth. The stock trays really, really do help. They come in different large, small, medium, and different jaw shapes as well. And they also make partially dentulous trays, because you can use the same technique for someone who's still got their anterior teeth and you want to make a partial, or if you're getting ready for an immediate denture, right? So yeah, that makes a difference. There are some people who have such big ridges. You could use a regular dentate tray, don't get me wrong, right. but not for everybody.
And these are fully perforated trays, right?
Yeah, I use fully perforated trays. Yeah.
Okay, great. And then you mentioned the syringe, 60 milliliters, no tip. Where's that available from?
I typically go online and buy them off Amazon and Becton Dickinson makes them, but we will typically just buy them off Amazon. Yeah.
Okay, and then I guess during the video you mentioned something about preventing voids in the alginate, and that the individual couldn't hear exactly what was said. How do you prevent the voids in the alginate?
Well, a major area that's important to capture in the impression is the vestibule in its functional state, right? Now, there's different ways of border molding. Some people will have the patient suck on their finger. Some people will manually manipulate. Whichever technique you use, if you don't get the alginate up into the depth of the vestibule to begin with, you're going to get voids up there. And so the syringe is what, by pulling the cheek out, and actually you can see the syringe as it works its way forward, you know that you're not trapping any air up there. Even then, if you don't have quite enough material in your tray, you've already got alginate up there. And when you seat the tray, it's really rare for us to get a major void up there in the vestibule. If I have a little void in the palate or a little void somewhere else, I can live with that. I can manage that. But if I have a major void, sometimes I have a major void in the palate where I didn't put any rope wax on the palate to support the alginate and it just wasn't enough. You have a big arch, you might mix an extra scoop of alginate, that kind of stuff. But yeah, the odds of getting voids in those areas just goes down dramatically.
Okay. When you have your impression, you see some thin areas where maybe you can see the tray or you can see the rope wax. Are these indications that you're going to have sore spots later on, or what's the criteria?
So what I find is that when it's in the rope wax, no, because the rope wax is pretty soft. It doesn't really. It's basically just like a slightly thicker impression material in a way, and the tissue will mold it. If I have burn through where I'm back to the tray, depending upon where it is, sometimes, yeah. So if I have a lot of burn through that worries me, I'll actually write myself a little note that says, okay, you might have some struggles here over the incisive papilla because you had burn through. And so, but I will find that it depends where the burn through is. And the maxilla, if I have a bit on the crest of the ridge, that's fine with me because that's where I want the stress to go, right? So I don't worry about it so much. In the mandible, again, if it's an area where you don't want extra pressure, I might write myself a note. Yeah. Okay. And you can't go back and wash these things. It's not like you're going to go back and do a second layer. If there's something about the impression you don't like, you just got to rip it out of the tray and do it over.
Right. Or you could photograph it so you'll know where all the thin spots were.
Yeah.
Okay, so you were pretty clear that CR is not the determining factor, not the ultimate jaw relationship that you're going for here. But what is the ultimate jaw relationship that you're going for? Because I got a lot of questions about how do you determine CR. So there's a lot of folks that are kind of stuck on that CR idea. Yeah. You're saying CR is not the only jaw position that you can use. How do you determine what position to use?
So historically, people used to think of CR as being the most retruded position of the mandible. And so people would put this retrusive force on the mandible while the patient was closing into the registration, right? And over the years, we've kind of decided that's not such a good idea. And now we just want the condyle seated anteriorly against the eminence. But again, you can't know any of this stuff. I mean, it's all just, it's not hearsay, but you get my point, right? So what do I want? I want a position that the patient can close into repeatedly the same place over and over again. That's more important to me than anything else. If that happens to be in centric relation, great. If it happens to be somewhere else, great. So I want them to be able to find a position that is comfortable for them, that they can go to over and over and over again. That's the two things that I care about. Now, some people may not be able to do that easily, and maybe you pick a denture tooth that is flatter, so they have a little more freedom to work around, right? That would be a different presentation. But the point here is that we get hung up on this position that actually is not the purpose, right? So if somebody doesn't have it now, if I walked into a dental school and somebody said to me, well, it doesn't matter, just find a position that's repeatable. The dentist in us doesn't like that. We want something a little more hardcore or definitive to go chasing, right? But if you go to the why of CR being good, it's just because it's an unstrained position, it's not uncomfortable to get to, and it's repeatable.
Got it. A question about immediate dentures. So, again, if there's teeth involved, obviously, then the jaw relationship is a lot harder to manipulate and to capture. What do you do as far as a jaw relationship for an immediate denture?
So that goes back to which teeth are left. So if the patient has a centric bite position with their teeth and they're comfortable in that position, we're just going to mount the case in that position. We're not going to change it. We're definitely not going to go looking for centric relation because they're already comfortable in that position. If they don't have any posterior occlusion or any way for you to capture something that's stable with their existing teeth, then you go back to the philosophy that I just used for centric relation. It's for complete dentures. It's what is comfortable, what is repeatable. If they've got teeth, though, we use the teeth.
And what if you're doing a full mouth rehabilitation on a patient with teeth? Is it, once again, CR is not the holy grail? It's a repeatable, comfortable position?
Yeah, exactly. Let's say you have a patient that comes in with a repeatable, comfortable maximum intercuspation, and you change it, right? And they're not comfortable anymore. Like what was the point of changing it? So if you're going to do that, and sometimes we will do this with vertical dimension changes, even with fixed scenarios, you need to test it with some kind of occlusal splint or something that tests the new position before you commit to it. That would be my advice.
Okay. Now, questions about your FASBO comments. If you're not using a FASBO, how do you establish occlusal plane? Well, I mean, that's something you do with a Fox plane anyway, right?
Yeah.
Not a FASBO.
Right. So occlusal plane, I tend to use either anatomic landmarks like the retromolar pad and the posterior, the rim, which you've established its length for aesthetics and phonetics in the anterior and lip support. You can use the alar tragus line if you want to. You can use the interpupillary line for this dimension. Yeah, the Fox plane. You can use aesthetics, but those things are all more related to where you want to set the maxillary teeth or the mandibular teeth to establish the plane, rather than needing to know what the arc of closure is, which is what the FASBO would give you.
Okay, I'm going back to some questions that have just come in. The question is, can we use PVS instead of alginate? I'm going to assume they mean in a stock tray using rope wax. Can you then just substitute polyvinyl siloxane for alginate?
So if you're going to do that, you can do that, yes. So the answer is yes. You're going to give up, you're going to be spending more on the material, but if that's what you want to do, that's great. I would not use rope wax in those scenarios. If you're going to do that, I would actually border mold a tray with a sort of heavier body PVS, border mold it, and then come back and do the wash with the light body.
Okay. And on the impression topic, what about intraoral scans for complete dentures?
Yeah, again, back to my earlier comment that they're coming, but our ability, I mean, we can scan the attached tissue really well, but our ability to record the movable tissue in its functional state or some kind of active state we're still not there yet with intraoral scans.
Okay.
But it's
Here's a
coming.
good one. How do you communicate expectations to a patient needing a complete lower denture but has poor anatomy? So the patient can't afford an implant-supported denture, but we want to make sure they have the proper level of expectation. What would that talk track look like?
So there's two ways of going. If the patient is difficult to please, if you believe they have unrealistic expectations, then I think it's the line I use is that I was taught by Ron Desjardins at Mayo. He says, Sree, you have to have a line that shows that you care, but also says you're not going to do it. And so the line he taught me was to say to a patient, I guarantee you that I cannot help you. And so you got the word help there, meaning you'd like to, but the guarantee part says, I'm not going to do this. So that's that patient. The other patient, though, that is reasonable, what I say, a lot of times I will say to them, when we look at your lower jaw, with the tongue wanting to lift the denture and looking at how much bone we have to hold on to, I'm going to tell you that it's really going to be very difficult for you to wear a denture that doesn't slide around. So that means you're probably going to be uncomfortable. There's going to be some sore spots. And I'll make you the best fitting denture that I can, and we'll create the best bite for you that we can. But just a foundation that what we have to work with is so compromised that even with that, the denture is going to be moving around a lot and sliding a lot. And I'm really not sure how well you're going to be able to eat with it. It's going to look good, but when the dentures move, it makes it difficult to speak and it makes it difficult to eat. And if you would like me to go ahead and then still make the denture, I'm happy to do it. But I just want you to know that it's going to be hard.
Yeah, of course, patients love to prove you wrong. And when you tell them that they're not going to be able to use this denture, they would love to show you that they can use it very successfully. Exactly.
And that you might have to use denture adhesive, but even that is not the funnest thing to do. And yeah, they do like to prove you wrong.
I'm going to close with one of our attendees, Dr. Walter, and it's not a question, but a comment. He said, it's wonderful to hear a prosthodontist speaking of these techniques. I've been doing full dentures this way for 30 years with no problems and great results. And thank you for the affirmation. So yeah, there's been some experimentation and some release of dogma. And having you here today has been very, very helpful. I can't wait for a couple of weeks from now when we have our complete denture symposium and have you out there and teaching some of these techniques. So thank you very much, Dr. Sree Koka. It's always a pleasure to work with you, and another great lecture. And thanks everyone for joining us today. And we'll see you back next week when we'll have, as always, our business advisory panel. And our topic will be the single unit implant, analog and digital restorative workflows. This is an area that's seeing rapid technological advancement. And much of that advancement is being led by our speaker next week, Dr. Taylor Manalili, who's head of prosthodontics here at Glidewell. So you don't want to miss that, and we will see you then. Thanks, everybody. Thanks, Nicole, and thank you, Sree. Take care.